This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is Dr. Deepak Megur, and in this video I'll be speaking on some of the basic aspects of surgical skill acquisition. This is going to be helpful for most beginner surgeons, and the topic for today is how should we learn any new surgical skill. So that's what I'm going to speak on. This presentation is aimed primarily at the budding eye surgeons who are at the beginning of their career or at an intermediate level of learning. So this talk is dedicated to my teachers. So how do we learn any surgical skill? The standard methodology which we all have followed is these things, and it's also right that first we need to observe a lot of these steps, read about it, see it being performed by our mentors, interact with them, and practice this in wet lab situation. So this is what the standard teaching is, but I would say that we would want to do something extra here. So I'd like to add a couple of more points to all of the above said things. When we start learning any surgical step, I think we need to answer these two questions first. What can go wrong and why or how can it go wrong? So identify a step which you want to do and then write down all the things which can go wrong. So when we are in surgery, we need to remember that ignorance is not bliss. So we need to be absolutely sure about what are the things that can go wrong. By that, we are already aware of all the complications that can happen with each step. So we are better prepared with the modifications to avoid these complications. And we're also prepared to identify these complications at the earliest, and then we can minimize the eventual damage. Let me take you through a very simple step like incision, which is often taken for granted. The first obviously would be, which is quite a common thing, you don't realize that the tip of the blade can be damaged and you're struggling to pass the blade across the tissue, and which can result in a very serious complication as a descendant membrane detachment. The incision can be too small or too tight, or it can be too big. The tunnel which you created could be too short and hence unstable, or we could create a very long intracorneal tunnel which can cause intraoperative problems. We can have a too posterior incision or we can have a too anterior. So this is some of the list which we can prepare just trying to learn a simple step as an incision itself. Let me take you through another very simple step, that is OVD injection. Okay? So what can go wrong when you're injecting OVD into the eye? The site potencies you made could be too small to introduce the scanline site. And if you're struggling to introduce the cannula and try to inject at the wound, you could induce descendant membrane detachment. And rarely there could be a situation where the cannula would not be fitting very tightly to your syringe, and when trying to inject OVD, you could have the flying cannula syndrome. The cannula can just fly across and damage intraocular structures. Even a simple step like OVD, if your mind is prepped on what are the things that can actually go wrong at every step, you'll be much more prepared to prevent these unforced errors. So the next time you're introducing the OVD cannula, you are very sure that the incision is appropriately large enough to allow the cannula effortlessly into it. And before you introduce the cannula, you check whether it is fitting properly, and also you stabilize the cannula in a particular way so that inadvertently it should not slip out. So these are very basic etiquettes which one needs to learn even before we do our first cataract surgery. So let us look at another surgical step. An eye surgeon is wanting to learn the technique of CTR insertion. Again, the first thing we need to do is to write down the list that can go wrong. Number 1. Difficulty in handling the CTR itself. The first time you're going to handle the CTR, it's going to be very flimsy, you're not sure about its consistency, and more often than not, it's going to jump out and fall. When you're introducing the CTR, you can just misplace, put it in the sulcus itself. We can induce posterior capsular tear while trying to ferociously negotiate a CTR into a capsular bag. We can worsen the pre-existing zonal dehiscence if you are not careful and gentle enough. Of course, we can break the rhexis when you're trying to negotiate the CTR in. The CTR may itself break, and rarely in the presence of a PC tear, we can lose the CTR into the vitreous cavity as well. So these are potential side effects which can happen when trying to introduce a CTR. Well, this list is not to scare you all, but it's important that we acknowledge about the possibility of these side effects. So before we introduce the first CTR itself, we know what are the things which can go wrong, and we need to take adequate steps to ensure that the insertion is really smooth and safe. So the first thing obviously is to get a feel of the CTR itself. So use it in a normal case, hold it, and you should able to feel the consistency of this ring. And my recommendation would be to first begin to use it in some normal cases. How do I know that it's not gone into the sulcus and it's truly in the bag? Our goal is to place the ring into the bag. The one trick is to always keep the bag deeply inflated so that you have enough space to maneuver the CTR into the bag itself. But one telltale sign would be that always look at the edge of the anterior capsule where the CTR is going in. So there is a small kink which we note at the rhexis margin, and that is a clue that the CTR is truly behind the anterior capsule and not in front. Number 2, how do you prevent the PC tear? You're trying to negotiate the CTR. It's mandatory that we push it in a tangential way rather than pushing it vertically down. So it's important to remember that the path the ring is going to take is tangential along the equator of the capsular bag. So we need to be mindful of the surgical anatomy here, and we cannot show it posteriorly. So that's going to put a stress on the posterior capsule, and there's always a risk of tear. Obviously, inflating the bag very well with the OVD does help. So zonal adhesins, again, if you're able to keep the bag very much inflated with OVD, the amount of zonal stress which is going to be induced while threading the CTR inside can be minimized. And when we have a localized area of zonal adhesins, always trying to support that area early on during the course of your CTR manipulation does help. And using the second instrument to compress the CTR as the ring is being negotiated into the bag is the third point by which we can minimize the amount of zonular weakness which can be induced while threading the CTR inside. Of course, there's always a risk of tearing the rhexis margin, which is very unlikely, but some of the capsules can be very fragile, especially long-standing cataracts, and there could be a risk of tearing the rhexis margin itself. So obviously, if one has missed a peripheral PC tear and you are threading in a CTR, there's always a risk of the PC tear enlarging, and there's a potential risk of the CTR dislodging into the vitreous cavity as well. And lastly, there could also be a possibility of breakage of the CTR, and in those situations, we need to be adequately prepared to manage it. If the CTR breaks when you're trying to maneuver, if the CTR is still accessible, we can remove that pieces. And if one of the portion is not accessible and is safely in the sulcus or in the bag, then you can consider leaving it because fishing it out could be extremely traumatic. Now moving on to the next step of learning a new surgical step or a maneuver. Now, assuming that we want to learn a new surgical maneuver, my recommendation to all my trainees is to divide this surgical step into multiple smaller maneuvers. Now, let me take you an example of creating an incision. Now, this is the main phaco incision is being created. So we can see that the blade just goes in, creates a corneal tunnel, perforates the descendant membrane, and we're through. So the incision is created. Now, let me break this step into multiple smaller components. First, the globe is stabilized. The eye is turned away from me a little bit. Then the blade is introduced parallelly. So this maneuver ensures that I have a corneal tunnel which is measuring about 2 mm. Then the globe is turned a little bit towards me. Then at this stage, the blade is tilted just a little bit, and then the descemet is perforated. And the plane of the blade when it enters into the eye is always parallel to that of the iris. Now, this ensures that we have a secure valvular action of the cornea still present, and we have got a strong 2 mm length of the incision. So to revise, the globe is turned away, you enter into the eye, the globe is turned a little bit towards you, and then you perforate the chamber into the eye with the blade being parallel to that of the iris. The incision is broken down into maybe 3 maneuvers. So let me take you through another step, that is, somebody wants to learn a vertical chop maneuver. So this is the vertical chop which is done by an experienced surgeon. You just go in, hold the nucleus and chop it. So let me try to break this maneuver into multiple small maneuvers, okay? Number 1, first engaging the nucleus itself. So the foot pedal goes to 3. There's a short burst of energy which is given. This ensures that you're going to engage the nucleus. Then you need to bury the tip a little bit deeper into the substance of the nucleus depending on the density of the nucleus. This is number 2 step. And once you've buried the nucleus sufficiently deep, then we're going to move to foot pedal 2. That is in just an aspiration mode, just holding the nucleus there. Number 4, the nucleus is slightly pulled up with the phaco tip just a bit. Number 5, the non-dominant hand with the chopper is kept just in front of the phaco tip. It moves down and then laterally. The right hand, which has the phaco tip, is holding steady or is gently moving up. It's not moving down. So the vertical chop, I've tried to divide into 6 maneuvers. It's almost like, watching an action film in slow motion. So you're going to break this step into 6 smaller maneuvers, which are going to help us to master the finer nuances of each step. So again, even when you're not in the OR, you have to practice this maneuver with your hands and your mind. So practicing in the mind helps a lot. It's not just about doing the surgery in the wet lab itself or on the patient itself. You have to do the surgical steps in your mind 1,000 times before we actually do it on a live patient. So that's the sort of commitment one has to have when you're trying to learn any new thing. So practice it multiple times in your head before you actually do it with your hands. So these are a few of my thoughts regarding how do you learn any new surgical step. That was it. Thank you for watching and hope you found this helpful.